All right. Good morning, everyone. Thank you for being here. It is a distinct honor to introduce Dr. Brian Ho, a prominent figure in the field of neurosurgery and cerebrovascular disease, as our guest speaker for Grand Rounds talk today. Dr. Ho graduated from Stanford with Bachelor of Arts and Science degree in biology and political science. He attended medical school at Columbia here in New York, and then went on to complete his neurosurgical residency and endovascular fellowship at MGH at Harvard. Dr. Ho's substantial research portfolio covers a wide spectrum of topics with an impressive publication record that exceeds 200 articles and book chapters. His exceptional academic and clinical work has earned him many awards and accolades, both globally and nationally. Dr. Ho is an international leader in neurosurgery as well. He's the past president of the Congress of Neurological Surgeons. He's also a past chair of Joint American Association of Neurosurgeons and Congress of Neurosurgical Surgeons, Cerebrovascular Section, and a senior member of Society for Neurointerventional Surgery. He's currently chair of Lillian S. Wells Department of Neurosurgery at University of Florida. He has been funded continuously for many years. Dr. Ho is an NIH-funded PI for the CAPTIVA study, which is ongoing, and some of our residents are very well aware, since our Kings County Hospital is part of this multi-center prospective RCT. Today, we're delighted to have Dr. Ho as our guest, and he'll be telling us more about this wonderful project. Thank you for being with us, and you can continue.
Great. Thank you, Johannes. And what an honor to be invited. And let me get share screen going here. Is this in slideshow presentation for everyone?
Yeah, we're seeing the presenter's view, actually.
Oh, presenter's view. Let me change this. Is that better? Is it still presenter's view?
No, it's good now. Yeah.
Okay, great. All right. Well, thank you. And again, you mentioned Kings County is participating in CAPTIVA. Not only is Kings County participating, I see Susan is here. Kings County is our leading enroller in CAPTIVA. And we'll talk a little bit about this in the presentation, but CAPTIVA is a national multi-center randomized clinical trial. And last I looked, I think Kings County has enrolled 17 subjects in CAPTIVA and is our leading enroller. So I'm very grateful and very thankful that your department, your medical center is very interested and enthusiastic in this endeavor. These are my disclosures, some of which are relevant. CAPTIVA is funded by NIH U01 and Janssen, which is the maker of rivaroxaban, is providing low-dose rivaroxaban for CAPTIVA, and AstraZeneca, who is the maker of ticagrelor, is providing ticagrelor for CAPTIVA. So symptomatic intracranial atherosclerotic disease is one of the most common causes of stroke worldwide, and it accounts for about 8 to 10% of stroke in the US, so roughly about 80,000 strokes per year. But the natural history is extremely severe. The one-year rate of ischemic stroke, intracerebral hemorrhage, or vascular death from symptomatic ICAD is 27%. But despite its importance, it's a relatively understudied disease compared with other conditions such as carotid stenosis or AFib. There is racial disparity. ICAD is found in 90% of Blacks, 83% of Japanese, and 12% of whites who present with anterior circulation ischemia. And Chinese living in the US have higher rates of ICAD than whites, and similar to Blacks and Japanese. Now, many of you are familiar with previous clinical trials in ICAD. One of the earlier ones was WASID. My co-PI in CAPTIVA, Mark Chumowitz, led this trial. It was a randomized trial of patients with greater than 50% symptomatic ICAD, and they were randomized to two arms, either Coumadin or high-dose aspirin. And the WASID was stopped prematurely after 569 patients were randomized because of safety concerns. And this was primarily driven by the higher rate of hemorrhage and death in the patients that were randomized to the warfarin arm. That safety concern, again, was driven by the higher rate of death. But in a post-hoc analysis of the on-treatment patients in WASID, what the investigators found was that actually most of the death and hemorrhage in the warfarin arms were in patients whose INRs were supratherapeutic, above the target range, and higher rates of stroke in those patients in the warfarin arm that were subtherapeutic on warfarin. But there was actually a sweet spot for those patients in the warfarin arm that were in the therapeutic range of warfarin. Now, the next major clinical trial in ICAD disease was SAMPRIS, which was a randomized clinical trial, again led by Mark Chimowitz, which randomized patients with 70% or greater ICAD to either angioplasty and stenting or medical management. The primary endpoint was a composite of stroke or death within 30 days, ischemic stroke in the territory of the ICAD in greater than 30 days, or stroke or death within 30 days after a revascularization procedure. And this trial, like WASID, was stopped prematurely because of safety concerns. The median follow-up for those patients enrolled in SAMPRIS was about 3 years. But the primary endpoint, and again, driven by stroke or death, driven by safety concerns, any stroke or any major hemorrhage in the angioplasty and stenting arm, and these were by far peri-procedural. Well, the effects of SAMPRIS is that it really influenced and changed the practice and management of ICAD in the United States, at least. Tanya Turan, who's a co-I in CAPTIVA, conducted a survey of US neurologists and neurointerventionalists 1 year after SAMPRIS, and 82% of respondents indicated that SAMPRIS changed their practice, and most clinicians who are taking care of patients with ICAD in the survey indicated that they were treating patients with maximal medical therapy, mostly consisting of dual antiplatelet therapy and aggressive medical therapy. However, given that, there is need for better treatment because the natural history for symptomatic ICAD is extremely poor. The SAMPRIS trial showed that the event rate when using the AHA definition of stroke is over 20% within 1 year. In the Chinese ischemic preconditioning trial, at 1 year, there's a 27% rate of recurrent stroke. In the VISIT trial, 9.4% rate of stroke in the territory of the stenotic artery. The Northwestern Prospective Registry, 23% risk of recurrent stroke in the territory of the stenotic artery at 30 days. In the Oxford Vascular Registry, 23% risk of stroke or death at 2 years. And in the Myriad trial, almost a 25% risk of infarct in the territory of the stenotic artery at 6 to 8 weeks. So a very, very severe disease with a very poor natural history. Now, the current standard of care, or what surveys have indicated most US practitioners how they're treating ICAD, is with dual antiplatelet therapy. And just a very brief kind of summary of the type of antiplatelet therapies that we have. I think most clinicians are using a combination of a P2Y12 antagonist with aspirin. Remember that clopidogrel, ticagrelor, Ticlid, prasugrel, these are P2Y12 antagonists. Aspirin is a COX-1 inhibitor, but there are other antiplatelet agents such as GP2B3A blockers, as well as phosphodiesterase inhibitors. And I'll talk a little bit about cilostazol later. What is the rationale for dual antiplatelet therapy? Well, I think that one could say that we have borrowed this from our colleagues in cardiology. And the rationale is an assumption that perhaps the pathophysiology of ICAD is similar to acute coronary syndrome. And there have been many cardiology clinical trials that have examined this and shown a benefit of dual antiplatelet therapy compared to aspirin monotherapy, one of which is the PCI Cure trial, which showed there was a benefit of Plavix and aspirin over aspirin monotherapy in reducing the rate of cardiovascular death, MI, or urgent revascularization in ACS patients. With many practitioners using Plavix and aspirin, there have been subsequent trials that have looked at alternative antiplatelet therapies. The Triton-TIMI 38 trial examined prasugrel and aspirin versus clopidogrel and aspirin and found a benefit with prasugrel and aspirin, albeit with an increased risk of major bleeding and life-threatening bleeding. And then the Plato trial examined ticagrelor and aspirin versus clopidogrel and aspirin in acute coronary syndrome patients and found a benefit in terms of reducing vascular death, MI, and stroke. However, did find increased risk of major bleeding not related to coronary artery bypass graft surgery. What have been the clinical trials in terms of dual antiplatelet therapy for stroke? Well, there have been a number of them, and I'll include some of them here. The CHANCE trial, which was conducted in Asia, randomized patients with minor stroke or TIA to clopidogrel and aspirin versus aspirin monotherapy and found a benefit in the reduction of ischemic or hemorrhagic stroke with no increased rate of moderate or severe hemorrhage. The POINT trial, which was an international trial, randomized patients with minor stroke or TIA, again to clopidogrel and aspirin versus aspirin monotherapy, and again found a benefit in reduction of ischemic stroke, MI, or ischemic vascular death, much like CHANCE did, but however, the POINT trial did show an increased risk of major hemorrhage in the dual antiplatelet arm. The THALAS trial compared ticagrelor and aspirin versus aspirin monotherapy and found a reduction in stroke or death within 30 days in patients with minor stroke or TIA, and did find an increased risk of severe bleeding in the ticagrelor and aspirin arm. The only, one of the clinical trials that have compared dual antiplatelet arms was the PRINCE trial, which compared and randomized patients to ticagrelor and aspirin versus clopidogrel and aspirin. Now, this was randomized but open label, and the trial was not designed to look for a clinical endpoint, but rather to look at platelet aggregation. However, when they did look at stroke within 90 days, it did seem to show a trend towards a benefit of ticagrelor and aspirin versus clopidogrel and aspirin. But again, the PRINCE trial was designed as a platelet aggregation study. What have been the trials or evidence for dual antiplatelet therapy in patients specifically with ICAD? Those trials I just mentioned were for minor stroke or TIA. Well, the CLARE study was an open label study which compared clopidogrel and aspirin versus aspirin monotherapy in ICAD patients. But the endpoint was not a clinical endpoint. It was to look at TCD microemboli on day 2 and did find an improvement in microemboli in the patients on dual antiplatelet therapy with clopidogrel and aspirin. However, there was no difference in MRI DWI. The CHANCE trial did do a post hoc analysis of patients with intracranial atherosclerotic disease. And while they found that intracranial atherosclerotic disease had a worse risk of recurrent stroke, there seemed to be no benefit of dual antiplatelet therapy when they compared the two arms in that subset analysis. The THALAS trial in a post hoc subset analysis of patients with ipsilateral stenosis found a significant benefit with ticagrelor and aspirin versus aspirin monotherapy, and this was driven by intracranial stenosis, not by extracranial stenosis. However, they used 30% or greater stenosis as their criteria for this post hoc analysis. And then PRINCE, again, which was a trial looking at platelet aggregation, however, found that that trend towards an improvement in stroke was mostly found in those patients with large artery atherosclerosis in a subset analysis. Now, all of the antiplatelet agents I talked about in the cardiology trials, as well as the stroke and ICAD trials, were P2Y12 antagonists. There are phosphodiesterase inhibitors, and cilostrozol is one of them. And there have been a number of trials conducted in Asia examining the benefit of cilostrozol. Now, in the CSPS trial, there seemed to be a benefit in reducing recurrent cerebral infarction in those patients that were randomized to cilostrozol versus placebo. And in the CSPS2 trial, there was a reduction in stroke in patients with cerebral infarction that were randomized to cilostrozol versus aspirin monotherapy. And surprisingly, in CSPS2, there were actually fewer hemorrhagic events in the patients that received cilostrozol over aspirin monotherapy. Now, TOS2 was a trial not to look for a clinical benefit, but to look for primary progression of ICAD on MRA in patients with acute symptomatic M1 or vascular stenosis. Patients were randomized to cilostrozol and aspirin versus clopidogrel and aspirin, and there seemed to be a trend towards reduction and progression of ICAD on MRA. The Catharsis trial, again, was not a clinical benefit trial, but a trial to look at progression of ICAD on MRA, did not show a benefit of cilostrozol and aspirin versus aspirin. And then CSPS.com was a clinical trial that randomized patients with non-cardioembolic stroke and greater than 50% intracranial or extracranial stenosis or greater than 2 vascular risk factors. It was open label, but randomized patients to dual antiplatelet versus mono antiplatelet. And the dual antiplatelet was cilostrozol and aspirin or cilostrozol and clopidogrel versus monotherapy, which could be aspirin or clopidogrel. And this found a significant reduction in recurrent ischemic stroke in those patients on the dual antiplatelet arm. But remember, the dual antiplatelet arm could be cilostrozol and clopidogrel, not just cilostrozol and aspirin. There are some caveats to the CSPS.com trial. One is the trial was stopped early. It was conducted only in Japan. And again, the reduction in ischemic stroke was driven primarily by the patients that received cilostrozol and clopidogrel. And if you look at the Kaplan-Meier curve, the ischemic stroke rate was identical between the two arms in the first 100 days. If it really was some benefit of the antiplatelet effect of cilostrozol, then you would expect this not to level off or plateau after the first 100 days. So it suggests maybe there's some pleiotropic effect of the cilostrozol rather than an antiplatelet effect. And then a great number of patients in the trial discontinued the study drug in less than 6 months. So what is the current management of ICAD? Well, in a survey of StrokeNet sites that we conducted, 80% of sites indicated that they're currently managing ICAD with aspirin and clopidogrel, some with full dose aspirin and some with baby aspirin. 92% of sites indicated they are not conducting CYP2C19 testing, and I'll get into what that is. So clopidogrel, remember, is a prodrug. It's an inactive form when given and requires cytochrome P450C19 enzymatic activation in the liver to become the active form of the drug. It's estimated about 30% of the population in the United States carries a single nucleotide loss of function polymorphism that renders them unable to or have a reduced ability to activate clopidogrel to the active form of the drug, reducing their clopidogrel efficacy. However, there's conflicting evidence in the cardiology literature on whether CYP2C19 genotype matters and whether we should be checking for CYP2C19 genotype in guiding our antiplatelet regimen based on it. And thus, current stroke prevention and cardiology guidelines do not recommend routinely performing genotype testing. So there have been multiple acute coronary syndrome trials which have looked at whether CYP2C19 genotype testing should be performed. The PharmClo study randomized ACS patients to either a standard arm. You may wonder why there's all these different agents. Well, remember, there were the acute coronary syndrome trials that showed a benefit of ticagrelor, the Plato trial, the Triton-TIMI 38 trial, which showed a benefit of prasugrel over clopidogrel. So I believe our cardiology colleagues use a variety of different dual antiplatelet agents. Or a genotype testing arm with which patients who were randomized to this arm underwent CYP2C19 genotype testing, and if they were loss of function carriers, their dual antiplatelet treatment was switched to a different testing agent. And this PharmClo trial seemed to show a benefit in performing CYP2C19 genotype testing. The Popular Genetics trial, again, randomized ACS patients to a standard arm versus genotype testing arm, and seemed to show a non-inferiority benefit of genotype testing over standardized testing. However, the Taylor PCI trial randomized patients to a standard arm versus a genotype testing arm. However, unlike the previous trials, this one did require that patients in the standardized arm be on clopidogrel. And the genotype testing arm was based on CYP2C19 genotype testing. And Taylor PCI failed to show a benefit of CYP2C19 genotype testing guided dual antiplatelet therapy. Now, in terms of stroke, last year, the CHANCE-2 trial was published, and this was a trial with which patients in China with minor stroke or TIA were genotype tested, and only loss of function carriers were included in this trial, and they were randomized to either clopidogrel and aspirin or ticagrelor and aspirin. And the CHANCE-2 trial showed a benefit in the reduction of recurrent stroke in those patients randomized to ticagrelor and aspirin. And this would seem to make sense if you believe that CYP2C19 genotype testing matters and that loss of function carriers have a reduced ability to activate clopidogrel. It makes sense if you only include loss of function carriers, ticagrelor and aspirin, which doesn't require activation through the CYP2C19 pathway, would have a benefit over clopidogrel and aspirin. However, I think there's a reason to believe we have equipoise after CHANCE-2. CHANCE-2 was 98% Han Chinese ethnicity, perhaps not generalizable to the US or North American population. There are a number of other trials, including POINT, when a post-hoc analysis was performed of CYP2C19 loss of function carrier status. There seemed to be no interaction or no benefit. The Maestro trial, prospective Japanese stroke registry, and evidence from ACS trials seem to point to equivalence or variance in terms of whether CYP2C19 genotype testing matters. And if you look at the Kaplan-Meier curve from CHANCE-2, all of the difference was in the first few days, and then the Kaplan-Meier curves plateau and are in parallel. And if you believe that there actually was a difference in the ability of clopidogrel to inhibit platelets in CYP2C19 loss of function carriers, these Kaplan-Meier curves should diverge, but they're parallel, indicating that probably the benefit of ticagrelor in this study was the faster onset of action of ticagrelor. And in fact, in CHANCE-2, if you looked at the subset of patients that were actually previously on antiplatelet therapy before being enrolled, there actually was a trend or a benefit towards clopidogrel, suggesting that perhaps it was the faster onset of action that benefited ticagrelor. And of course, there were higher total bleeding and other adverse events in the ticagrelor arm. I'll just go through this quickly. We had conducted a prospective trial of symptomatic ICAD patients at UF Vanderbilt and Marshfield Clinic. We obtained CYP2C19 genotype samples and performed genotype testing for loss of function and gain of function in patients, and actually found paradoxically an increased risk of recurrent stroke in those patients on clopidogrel and aspirin, and then in those patients that didn't have a loss of function carrier allele. Hard to explain why that would be true, but led to our conclusion that this needs to be studied with higher number of patients, and this still remains to be understood in ICAD patients. Well, this brings me to just a brief reminder of the major pathways for atherosclerosis and platelet aggregation and atherothrombosis in the setting of atherosclerosis. And these involve the COX-1 pathway, the ADP-P2Y12 pathway, but don't forget there's also a thrombin pathway. So while antiplatelets might attack the COX-1 and P2Y12 pathways, there is a thrombin fibrin pathway that's involved. And this provides a rationale perhaps for combining anticoagulation and aspirin, not just a P2Y12 inhibitor with aspirin. And what's the evidence for combining anticoagulation with aspirin? Well, the COMPASS trial, which was a trial of patients with cardiovascular or peripheral vascular disease, randomized patients actually to 3 arms: normal dose rivaroxaban, low dose rivaroxaban and aspirin, or aspirin alone. And the benefit of low dose rivaroxaban and aspirin was seen compared to aspirin alone in their composite endpoint of cardiovascular death, stroke, or MI. But this was driven primarily by a benefit in terms of the reduction in stroke. And in fact, in those subjects in COMPASS that had had a previous stroke, there was a significant decrease in the risk of recurrent stroke with a combination of low-dose DOAC and antiplatelet. The COMMANDER-HF trial was a trial of patients with heart failure, and again showed a reduction in any stroke or TIA or ischemic stroke in those patients with a combination of low-dose rivaroxaban and antiplatelet versus antiplatelet alone. Now, there's a wide variance in clinicians in the United States in terms of how long they keep patients on dual antiplatelet therapy for symptomatic ICAD. In Sampras, in both the medical and angioplasty and stenting arms, patients were on dual antiplatelet therapy for 3 months. But in Sampras, you can see that the rate of ischemic stroke in the territory of the stenotic artery more than doubled from the 3-month arm to the 12-month arm, and then plateaus off after the 12-month duration, indicating there's probably a need for dual antiplatelet longer than 3 months, but maybe not longer than 12 months as this plateaus afterwards. So perhaps 12 months is how long patients should be on in antithrombotic therapy. And in fact, in a post hoc analysis of Sampras, there were about 50 medical arm subjects who took clopidogrel and aspirin longer than 3 months for cardiac reasons. Again, this is a post hoc analysis and not powered to show any benefit, but there seemed to be a trend towards a reduction in stroke in those patients that were on clopidogrel and aspirin for greater than 3 months compared to those patients that were on it for 3 months or less. And any concern for risk of hemorrhage with dual antiplatelet therapy, it seems from prior stroke trials that the risk of hemorrhage from dual antiplatelet therapy is really within the first 30 days, and then it declines afterwards. So the highest risk of major bleeding is within the first 30 days, and there doesn't seem to be a difference between 3 months and 12 months. So this brings us to the CAPTIVA trial, which is a multi-center randomized clinical trial. I'll talk about the 3 arms. The clinical coordinating center is at the University of Florida, where I am. My co-PI is Mark Chimowitz at MUSC, and then the National Coordinating Center for StrokeNet is the University of Cincinnati, led by Joe Broderick. And again, this is funded by NIH. and Janssen is providing a study drug, as well as AstraZeneca is providing study drug. As the three arms in a double-blind phase 3 trial are ticagrelor, low-dose rivaroxaban, or clopidogrel. All patients are treated with baby aspirin and intensive risk factor management. Now, we designed CAPTIVA to be a two-stage trial. The first stage is safety. So after the first 450 subjects have completed 12 months follow-up, the DSMB will conduct a safety trial to look at the major safety endpoints of parenchymal brain hemorrhage or major non-ICH hemorrhage. And if the safety threshold is crossed for either of the arms, a futility analysis will be performed. And if the futility boundary is crossed, then that arm will be terminated. But if it's not, those arms will continue on to the second stage, which is an efficacy endpoint, which is looking at the composite endpoint of ischemic stroke, ICH, or vascular death. And the two experimental arms, either ticagrelor and aspirin or low-dose rivaroxaban and aspirin, will be compared to the standard control arm of clopidogrel and aspirin. An exploratory aim will be to look at the impact of CYP2C19 loss of function carrier status. So all study participants will submit a genotype analysis sample to the UF Genotyping Core Laboratory, and all treating clinicians and investigators will be blinded to that result. CAPTIVA is a StrokeNet trial, which I think many of you are familiar with, which is an infrastructure for conducting NIH-funded stroke clinical trials. All subjects enrolled in CAPTIVA receive these over-encapsulated pills to ensure double blinding. There are some drugs that are prohibited for participants in CAPTIVA. Obviously, omeprazole and esomeprazole are avoided because of their effect on clopidogrel. And the inclusion criteria are any patients who present within 30 days with an infarct due to 70% or greater stenosis of the ICA, M1 or M2, A1, P1, vertebral artery, or basilar artery. And these can be patients who pre-presentation have a modified Rankin score of 4 or less. They have to be 30 years or older. If they're 30 to 49, they have to meet these additional criteria to ensure that their stenosis is due to atherosclerotic disease and not due to dissection or moya, et cetera. And then exclusion criteria are things such as previous treatment of the target lesion with stenting or angioplasty or mechanical thrombectomy, plans to perform angioplasty or stenting, tumor or thrombolytic therapy, history of previous intracranial hemorrhage, major surgery planned, et cetera. Patients are seen at baseline, then 1 month, 4 months, 8 months, and 1 year. Again, the safety primary endpoints are parenchymal brain hemorrhage or major non-ICH hemorrhage. And the efficacy primary endpoint is a composite of ischemic stroke, ICH, or vascular death. And then adverse event reporting is extremely important and is according to these guidelines and are required to be reported immediately after that scene. Now, as we've conducted CAPTIVA, a number of sites have asked about unblinding in the event of bleeding and a consideration for giving Andexxa. And I'll just give this caveat. If a patient presents with life-threatening or uncontrolled bleeding and a treating physician calls the hotline will direct either to Mark or to me, and then we'll talk with the treating physician. And if there's major hemorrhage or life-threatening uncontrolled bleeding, then we'll unblind to either rivaroxaban or not rivaroxaban, so that the treating physician can consider giving Andexxa. But when we reach out to the company, they actually indicate that Andexxa, the indication for Andexxa is for normal dose rivaroxaban, not necessarily for low-dose rivaroxaban, which is the arm in CAPTIVA. Risk factor management is a major part of CAPTIVA, as it is for a number of other StrokeNet trials, including CREST-2. And the primary risk factors are LDL and systolic blood pressure with goals of less than 70 LDL and less than 140 systolic blood pressure. And part of the risk factor management is the Intervent lifestyle coaching program, which is a great benefit to the participants in CAPTIVA. And these are one-to-one risk factor counseling sessions that the participants in CAPTIVA receive, and these phone calls, checking in on the patients and talking through the risk factor management. And again, the risk factor management follows the timeline of the follow-up visits, 1 month, 4 months, 8 months, and 12 months. And again, the risk factor goals are an LDL less than 70 and a blood pressure less than 140. And this is the flow chart or the timeline of what's conducted for risk factor management at the initial visit as well as at the follow-up visits. And there is an algorithm in place for how to manage the systolic blood pressure, but the Risk Factor Management Center is always available for any phone calls and assistance in trying to manage blood pressures that are refractory to this algorithm. And this is the algorithm for risk factor management of the LDL. There are secondary risk factors as well, non-HDL, HbA1c, smoking, weight management, and exercise, which are provided here. There are standard of care labs that are considered, which we consider standard of care for CAPTIVA, but also for risk factor management. This is a flow chart of the study drug distribution. SHARP is the GMP facility for producing the study drug for CAPTIVA, but this gets routed to the University of Cincinnati, which is the National Distribution Center, and then they provide the blinded study drug to each site. For inclusion criteria, it's 70% or greater intracranial stenosis, and the measurement for the stenosis is using the WASU criteria. In other words, the diameter of the stenosis over the diameter of the normal vessel proximal to the stenosis. And the stenosis can be measured either on angiogram, CTA, or MRA, any one of them. But for CAPTIVA, if there's a discrepancy and multiple modalities were used, we are saying that DSA is the best modality, then next best is CTA, and then MRA third. And this is just an example of how you would measure stenosis in this MCA stenosis, D stenosis over D normal. You know, when you're designing a trial like CAPTIVA, you think that you have all grounds covered and everything planned, and then there are things that you don't anticipate and curveballs that happen along the way. And COVID happened, and then the introduction of the drug Paxlovid. Paxlovid, there's a warning that it can interact with clopidogrel, ticagrelor, rivaroxaban, and then the risk factor management drugs, statins and calcium channel blockers. So we ask that if participants get COVID, they should let their study site know immediately as possible. And if they do take Paxlovid, the standardized recommendation is to stop study drug for the 5 days that they are on Paxlovid, and then another 40 days, and then another 4 days for a total of 9 days. 4 days after they stop Paxlovid for a total of 9 days. But there is evidence coming out that there isn't really that dangerous interaction with Paxlovid with clopidogrel, ticagrelor, or rivaroxaban, and so we'll leave it up to the treating physicians and the sites on whether they want to stop study drug during Paxlovid use. And there are a number of alternatives to Paxlovid that are available. As many of you know, that each study participant has this trial alert card. There's a hotline phone number. If there's a need for unblinding, that phone number gets routed directly to either me or to Mark. Mark and I are the principal investigators. Here is our contact info, and then Renee and Stephanie are our clinical coordinating center. And again, there's a CAPTIVA hotline number. This is my neurosurgery department, which I'm extremely grateful for allowing me to devote a significant amount of time to CAPTIVA. And with that, I'd like to thank you very much and leave some time for some questions.
Thank you, Dr. Ho. Anyone who has a question, they can either unmute themselves or they can type it in the chat.
Dr. Ho, this is Ernest Barthelemy. Great to see you.
Hi, good to see you again.
Hi, how are you? So the data you cited, really great talk and interesting trial. The data you cited early on about the racial disparities was very impressive. Do we have any understanding of what we think is driving the higher incidence and prevalence in Blacks, Chinese, and Japanese versus white patients?
I think that it's very highly driven by a genetic component and not environmental or external risk factors. This is known. And in fact, in CAPTIVA, we are seeing that, which we are seeing as successful because we sought to increase the diversity of study participants in CAPTIVA, that a large number of our patients in CAPTIVA are African American. We aren't seeing as many Asian, maybe just because of the population that's surrounding the sites that are involved in CAPTIVA. But we know that in a number of the Asian stroke trials, that most of the participants in the Asian stroke trials were patients that had stroke from ICAD. So I don't think we know the gene responsible or why, but it seems very much to be not an environmental risk factor phenomenon, but driven by genetics.
Interesting. Thank you very much.
I have one quick question. So you mentioned, sorry, you mentioned for symptomatic ICAD, the dual antiplatelet duration of therapy, usually traditionally 3 months, and there is a continued benefit after it. The guidelines normally that what we use right now, we just do 3 months and then monotherapy after that. Is there any change in the guidelines down the line, or we need more studies, or are there any studies that are out there trying to look for this continued benefit for dual antiplatelet therapy?
Yeah, good question. I am unaware of any studies that are randomizing patients to 3 months versus 12 months. Interestingly, guideline recommendations and standard care 3-month duration of dual antiplatelet is really not based on any studies that have shown 3 months versus any other duration, but rather it just happened to be that Sampras just kind of chose 3 months as a duration in both arms of Sampras. The angioplasty and stenting arm and the medical management arm were 3 months of dual antiplatelet. And I think that practitioners just kind of adopted that, or for whatever reasons, clinical experience, have chosen 3-month duration for antiplatelet. But I think there's rationale from Sampras and other studies that show a continued increased rate of recurrent stroke in ICAD patients past 3 months up to 12 months. Or justify a 12-month duration for antithrombotic therapy.
Thank you.
I see Steve Levine is on the call. He's our medical adjudicator for CAPTIVA. So So with Steve as a co-I in CAPTIVA and Kings County being the leading enroller, I think SUNY Downstate is a major player in the CAPTIVA trial.
Thanks. Great talk, Brian. Great update.
Thank
Appreciate
you.
it.
Thanks.
All right. I guess that's all the questions. I don't see anything in the chat. Thank you so much for being with us, and it was a very great lecture. Thank you for this great update on the very important study, and we're very thankful that our sites are part of the CAPTIVA study, and we're proud that we're enrolling patients. We'll continue to do so.
Great. All right. Thank you, everyone, and happy holidays.
Thank you. Happy holidays.
Happy holidays. Thank you.
Bye.